Sorry. Topic for our second talk is I wake up, I sleep, update on ICU sedation. For this, I would like to call on stage Dr. Vipul Parekh, consultant and head ICU, Bajrangdasbapa Arogyadham, Bhavnagar, faculty of College of Critical Care Medicine, trained in Australia, area of interest, nutritional and palliative care.
Good afternoon, all. I wake up, I sleep, and I hope I don't make you sleep, because I'm here not to sedate you, but to discuss about how we can effectively use the sedation in ICU. Whenever we talk about sedation, the first thing comes in our mind is about midazolam or benzodiazepines. But a sedation doesn't mean just to make a patient calm or asleep. Your patient should be comfortable, your patient should be pain free, and he or she should have an comfortable overall experience in an ICU, because ICU stay is considered to be a war-filled experience in patients and family perspective. So we always talk about sedation, narcotics, but I have changed the sequence. Why analgesia, narcotics, and then sedation? Because pain is the most common memory what a patient carry when he or she is in ICU. Second is anxiety. Third, we use these measures for facilitation of mechanical ventilation, and sometimes we use it to avoid any self-harm or removal of any invasive lines or catheters, or while doing procedures. Why we are talking about sedations? Because any procedure, anything, it is not without risk. Sedation, it's always associated with prolonged ICU stay and mechanical ventilation. There is a risk of delirium, and there is a risk of adverse drug reaction due to sedative use. This is an era of bundles. So for also analgesia and narcotics and sedation, we have developed a bundle. It is access A, B, C, D, E, F. A is assess, prevent and manage pain. B is both spontaneous awakening trial and spontaneous breathing trial. C is choice of sedation and analgesia. D is delirium, assessment, prevention and management. E is early mobility and exercise. F is family communication and family involvement. Pain. Inadequate pain control is one of the major risk factors for nosocomial infection, longer duration of mechanical ventilation and precipitation of delirium. Even putting a Rayleigh tube, removing a Foley's catheter or doing endotracheal suctioning is a painful experience. So how to assess it? Simplest is numerical rating scale, that is 1 to 10. 1 is 0, 10 is excessive pain or worst pain what a person could have experienced. B is behavioral pain scale, where we assess the facial expressions from completely relaxed up to grimaces, 1 to 4. Movement of upper limb from completely relaxed, partially bent, completely bent with flexed fingers and trying to remove the lines. And third is compliance with ventilation or vocalization. Here the patient is completely cooperating with the ventilation, where here you are not able to ventilate the patients. Here patient is coughing, or here the patient is fighting with the ventilator. So accordingly we give the ratings, and based on the total of 1, 2 and 3 we decide the total behavioral pain scale. Third is critical care pain observation tool. It is the same as behavioral pain scale. We can use one of the tool which we are comfortable with. Now, whenever there is a numerical rating scale more than 4, behavioral pain scale more than 5, or critical care pain observation tool more than 3, or before performing any painful invasive procedures, or I will say all the procedures are painful, so any procedure we need to sedate, we need to give analgesics. And as our first lecture, we have lost our stethoscope. In the round we ask so many things, but we forget to ask our patients, that are you in pain? Or sometimes we fail to offer that I'm happy to give you painkillers if you want. I think the surgeons are not available, otherwise they feel that their surgeries are always pain free. They just put patient on Dolo 650 on the day 2. And that's something which should not be there. For them, a surgery worth 50,000 is not a costly, but paracetamol pint worth 250 or 300 is a great burden to the patient. So we have to ask the patient that are you pain free, and offer the patient, I'm happy to give you more drugs if you need it. Mostly they will tell you, yes, I need it. So keep your patient pain free. Second is spontaneous awakening trial and spontaneous breathing trial. Why we should do it? Because we want to minimize the sedative use and we want to use the lighter level of sedations. Because more the sedations we give, more the chances of complications. And secondly, most of the ICUs we are using benzodiazepines and particularly midazolam for sedation purpose. Now, midazolam has been shown to associated with increased incidence of delirium. But even though why we are using it? Because it is very easy. If everybody is using, there must be something good in midazolam as well. So, why we are putting our patient at risk of delirium by using midazolam? Because we are making them more sedated than necessary. That we'll talk in next few slides. So, to optimize the usage of midazolam, we need to do this spontaneous awakening trial and spontaneous breathing trial. This is Richmond agitation sedation scale, where we want to keep our patient somewhere around -3 level or -4, where there is a movement or eye opening on voice with no eye contact, or patient is not responding to voice but moves or opens the eye on minimal physical stimuli. That should be the level. Now, how to achieve this level? For that, can we use EEG? It's not routinely practiced, but EEG is the one by which we can find the sweet spot of sedation. Your patient should have slow wave sleep on EEG when you are giving a sedations. What happens? That we talked about error prevention module, just Ritesh Bhai talked in nursing workshop, that during the daytime your patient is receiving a sedation as per your wish, 4 ml per hour, 5 ml per hour, 3 ml per hour. But at night 10 p.m. they will increase the level up to 6 ml, 8 ml because they want to do other works, they want to reply to their WhatsApp, they want to do Facebook and so many things. And overnight patient receives 8 ml per hour infusion. Morning 6 o'clock again, patient is on 4 ml. So 8 o'clock round, everything is fine. This happens to every ICU. I think everybody will agree on that. So additional sedation leads to deep sedation with brush suppression. And it has been shown that more the time patient spends in brush suppression, there are more chances of delirium. And same way, from 8 ml, they will make it to the 4 ml, and at 8 o'clock, neurosurgeon will tell, okay, stop the sedation, I want to assess the neurology. So this rapid stopping of sedation also makes your patient prone to delirium. Bispectral index, it is usually used in OT to assess about the level of sedation by numerical scale when the muscle relaxants are being used. We can extrapolate the use of bispectral index into the ICU when we are using muscle relaxants. But be careful that bispectral value for each patient is individually different. So before giving muscle relaxant, we should assess the BIS value for given sedation level, and accordingly we should titrate or manage the patient on BIS. Now, spontaneous awakening trial. How to give spontaneous awakening trial? Confirm the suitability for awakening, stop or wean the sedation, reduce the narcotics by 25 to 50%, and achieve a RASH of 0 to 1, where patient is awake and has got eye contact. This is a very good chart. Your patient is fit to have a spontaneous awakening trial. So there is no active seizures, no alcohol withdrawal, agitation, no paralytics, no myocardial ischemia, and normal intracranial pressure, then your patient is fit to have spontaneous awakening trial. If patients become agitated, tachypneic, hypoxia, respiratory distress or cardiac arrhythmia at any given point of time, then your spontaneous awakening trial has failed. If you pass that trial, then you can go for the spontaneous breathing trial safety screen, where there is no agitation, maintaining saturation with less than 50% FiO2 and less than 7.5 centimeter of water of PEEP. There is no myocardial ischemia, no vasopressor use, and good inspiratory efforts. You can give spontaneous breathing trial, and if you succeed, then you can go for the extubation. Daily withholding sedations, if your patient is fit, and doing spontaneous awakening trial and spontaneous breathing trials will help you to extubate your patient early, and again it will minimize the use of sedations and associated complications. Now, choice of sedations and analgesias. I think benzodiazepine are universally being accepted, but nowadays the dexmedetomidine is coming in the recommendations that it has been associated with lesser chances of delirium. One study has shown that even though it doesn't improve overall outcome, but whatever days the patient lives, he will live without delirium. SADCOM trial again supports more on dexmedetomidine against midazolam. MENDS trial, it has shown that more days alive without delirium and coma when patient has received dexmedetomidine. But the only problem with dexmedetomidine is hypotension. This is a comparative chart about various side effects of the sedatives what we usually use in our ICU, from benzodiazepines, propofol, opioids, alpha-2 agonist and haloperidol, where prolonged winning respiratory depression and hypotension is common with all these three. Deliriogenic, it is more in benzodiazepines, we also seen in propofol and opioids. Tachycardia with morphine, and bradycardia with dexmedetomidine and haloperidol, and sometimes with propofol. So these are the other choices what we can use, particularly when we want to give a sedatives to our patients who are awake and just to have a comfortable sleep. Just give him dexmed, or you can give haloperidol, risperidone or quetiapine. Now, how to diagnose the delirium? I think this was the most difficult MCQ we have faced during our PG NEET exams. But here they have given a simplified approach, that is CAM ICU approach, confusion assessment method. If your patient has got acute change in mental status or fluctuating course, along with inattention, it is a very important sign, with either disorganized thinking or altered level of consciousness, then your patient is delirious. Whenever our patient is delirious, we should think of these are the causes of delirium. In the mnemonics is DR, doctor, and DRE, doctor DRE. Diseases, then sepsis, congestive heart failure, COPD, drug removal, either spontaneous awakening trial, sudden stopping of benzodiazepines, sudden stoppage of antipsychotics which patient was taking before admission to the ICU, environment, immobilization, sleep and day-night variations, hearing aids, eyeglasses and noises. I think these environmental factors are very much important, and where a training of our nursing staff is a pivotal role. Whenever we talk about how to manage delirium, if your patient is delirious, just don't bang them with the drugs. First is identify and treat the reversible causes. Then comes non-pharmacological strategies, and then comes psychoactive drugs, that is pharmacological intervention. There is no role of delirium prophylaxis with medications in ICU. Again, there are few studies which have tried to use prophylactic medications to prevent delirium, but it hasn't shown any benefit. For registrars in ICU, how to evaluate a brain roadmap for registrar to assess the delirium? Where is the patient going? So what is our target RAS? whether patient is ventilated, whether a patient is not ventilated. So first of all, we have to assess the RAS or sedation level, what we want to have. Then where is the patient now? So what is his current RAS level? What is the KM ICU status for delirium? And then we have to think, if patient is delirious or patient is over sedated, how he or she had gone there, and we have to correct it. So this is a very simplified approach for a registrar to manage the patients and to prevent delirium. Early mobility and exercise. All the patients, whenever possible, should be mobilized either in the bed, within the bed, outside the bed, or outside the ICU. Even daily 10 minutes of sunlight exposure would have much more beneficial effect to alleviate anxiety, delirium and all other issues, instead of giving more sedatives to the patients. Remove all unnecessary lines. Many times lines get removed when patient is about to discharge. And many times, like we used to joke that when you will remove the Foley's catheter, we used to tell the patients that once you settle down the bill, we will remove the Foley's catheter. But it should not be there. We should remove the lines, and if it daily in the rounds we assess that does patient needs lines, then we will end up removing all the lines at least 24 hours earlier than in the actual practice. Non-pharmacological measures: adequate daylight exposure, minimize night disturbance. This is very common in most of the ICUs. Nursing staff talking loudly, they don't switch off the lights, they are having other issues, monitor alarms are just ringing. We have to make sure a minimum night disturbance. Effective sleep awake cycle. To your conscious patient, just offer a cup of tea, they will be happy. Mobilize out of ICU, audiovisual aid during daytime in conscious patients. Remove lines. And last one, we love Saurashtra people, a Charottar product, tobacco. Just recently, I had one patient referred from Mahua. He was a highly irritable who presented 36 hours before with STLS and MI. A physician over there thrombolized the patient and he was highly irritable. So he suspected he could have intracranial bleed. And this is a time where CT scan was not available in Mahua. So he referred the patient, called me that I am sending a patient, he may need brain imaging and later on some intervention. On the way from Mahua to Bhavnagar, ambulance driver offered him a mawa, which he didn't get for last 36 hours. And by the time he reached Bhavnagar, he just stepped down of the ambulance and he told me, Jai Shri Krishna Sahib ke. So come Bhavnagar le aaya. Because by the time he sat in the ambulance, he was delirious. But by the time he reached to the Bajrangdasbapa hospital in Bhavnagar, he was completely fine. And he went back in the same ambulance back to his hometown. So sometimes don't withhold tobacco in your patients in hospital. It's criminal. એ બધું સ્મશાન વૈરાગ્ય જેવું હોય. હોસ્પિટલમાં બધા સારી સારી જ વાતો કરે કે હવે સુધરી જવું છે. But abrupt stopping of drug of addiction may harm sometimes to your patients. Doesn't mean we are promoting it, but we have to think of it. Same way, benzodiazepines, antidepressants, many patients are taking etizolam, benzodiazepines or say quetiapine or some other drugs, sertraline, then just continue those drugs. Family involvement. As sir said in the morning lecture, always involve the family, because families get involved, then the patients get more comfortable. Even the studies have shown that family presence during CPR, they reduces the chances of having dissatisfaction to the family and other medical issues. So involve the family to prevent delirium, to reduce anxiety and keep your patient comfortable. So sedation analgesia is not only a pharmacological management. I think it should be a more of humanitarian approach to overall the patients. And when multiple doctors are observing the patients, as sir showed that picture of elephant, we call them MODS. That is multiple observing doctor syndrome. So to conclude the things, ICU sedation should be protocolized, that includes down titration and daily interruption strategy. Multiple sedatives are available, but we have to choose accordingly. Propofol and dexmedetomidine will liberate the patient from mechanical ventilation faster than benzodiazepine therapies as per study. Use of benzodiazepine should be minimum. Cost of care calculation should consider the overall cost, not just the drug acquisition cost. Early mobility in ICU will help. Consider non-pharmacological managements and use typical and atypical antipsychotics medications if needed. Thank you.
Thank you so much, sir.